We are live.
Okay, I'll start. Good evening, everyone. Welcome to lecture number 483 of iFocus Online and Refractive Surgery lecture number 34. The topic for today is considerations after refractive surgery, that is dry eye management, to be presented by Dr. Akanksha Koul. Welcoming the chairperson for today, Professor Dr. Arvind Kumar Maurya, sir. Sir has done her MBBS and MS from MNAMS and is also a gold medalist. Sir received his fellowship in pediatric ophthalmology from Mahatma Eye Hospital, Nagpur, Maharashtra. Currently, Sir is additional professor and head of cataract, glaucoma, refractive squint, pediatric ophthalmology and medical retina services at All India Institute of Medical Sciences, Hyderabad. Sir was the first Indian to win the Ophthalmic Star Award at Amsterdam ESCRS 2021. He's also the AIOS International. He also won the AIOS International Hero Award for year 21, 22, 23, and 24. So he's also first to receive AIOS Senior Academic Achiever Award in 2021. He also received a gold medal in IIRSCI as Best Innovation, Best Cornea Video, and Free Paper Award. Issa has also received the Best Video Award in DOS. He has been conferred with around 12 Oration Awards. He's also received Best Video Award and IGO Honor Teachers of Tomorrow Best Poster Award by IOS. Sir has around 600 international and national presentations, 100 international and national publications. He's also the associate editor of UKJOS. He's the section editor of IGO, editorial board, member of EC Ophthalmology, WJCC, IGOVS, DOS Times, and JHOS. So he's also an international faculty at Cisco, WC, ICO, and ASCRS. We welcome you, sir.
Thank you so very much, Dr. Shreya, for your kind words.
Moving on to the moderator of today, Dr. Kanika Bharadwaj. She has done her MBBS DNB in FECO. She's done her MBBS from Mohan Kumar Mangalam Medical College, Salem, Tamil Nadu. She went on to do her DNB ophthalmology from Eye Care Eye Hospital and Institute, Noida, and further did her fellowship in cataract and refractive surgery from Center for Sight Eye Institute, New Delhi. She's currently associate consultant in CFS, cataract and refractive surgery. She's involved in training of DNB and PG students and mentoring fellows. She's also a recipient of multiple awards for Best Video, Best Paper, Best Poster at AIOS, DOS, WOS, SO, and various conferences. Received Young Researchers Award for her thesis. She has multiple publications on cornea, cataract, and refractive procedures in various national and international journals. Welcome, Dr. Kanika.
Thank you.
Moving on to speaker for today, Dr. Akanksha Koul. Ma'am is currently Associate Consultant for Center for Sight, Safdarjung. She's done her MBBS from Government Medical College, Bidar, Karnataka. She's done her DNB Ophthalmology from Shankar Devan Netralaya, Guwahati, and went on to do her fellowship in corneal and tear segment at LVPI, Hyderabad. She's the former faculty at LVP, Adilabad. She's also the section editor of cornea at Delhi Journal of Ophthalmology. She's a member of AIOS, DOS, and CSI. She's presented in multiple national and international conferences and has published articles in multiple national and international journals. We welcome you, ma'am. We may start the presentation. I'll just stop the screen sharing.
Thank you, Shreya, for that kind introduction. So while I'm just sharing my slides, I would like to thank Dr. Honavar sir, Dr. Mahipal sir, and the iFocus team for giving me this opportunity to be able to present today at this prestigious PG program. Are my slides visible?
Not yet, Dr. Akanksha. Now they are.
So the topic that I have been allotted today is a very important topic because it's a very common problem encountered by most refractive surgeons, and it's important also to understand what is the reason and the cause that these refractive patients have these complaints usually in the post-operative period. So now we know that refractive surgery has been having newer and newer technologies coming in. We started with traditional procedures like surface ablation procedures or PRK, where the epithelium was debrided, the excimer laser was fired, and then it took about 3 to 4 days for the epithelium to grow back. The visual recovery was a little slower. And then we moved on to flap-based procedures. We moved to LASIK, where there was a microkeratome, and then we shifted to femto-LASIK as well. And now with the newer procedures, which are lenticule-based procedures, such as SMILE or silk. We do have procedures other than corneal ablative procedures where we talk about ICLs, we talk about refractive lens exchange, which also come under refractive surgeries. But in the interest of time and the more appropriate topic that I would be covering in my talk today would be development of dry eye after the corneal ablative procedures. So, we all know that none of us want to see an unhappy patient, especially after refractive surgery, because these are patients who are young, they have high visual demands, they have great expectations from their surgeries. And if they are dissatisfied, it leads to a lot of dissatisfaction to the surgeon as well. And one of the main reasons that literature tells us for the dissatisfaction after refractive surgery is actually not residual error. It is not any complication during surgery, but it is usually symptoms of dry eye. So there have been various studies that try to tell us what is the exact prevalence of patients developing dry eye after refractive surgery. And that's a very variable number. But to put into perspective the major problem that we're dealing with, patients after refractive surgery, almost half of them. So, half of your patients are going to come up with symptoms of dry eye post any refractive surgery. So, like I said, between different studies in the literature review, the reported prevalence of post LASIK dry eye ranges from as high 5% in some cases. And what is more concerning here is that though it is transient, initially more in the first month or so, about 8 to 48% of patients can still continue to be affected even up to 6 months after having their refractive surgery. So the PROWL study or the patient reported outcomes with LASIK study reported that almost one third of patients who had a very normal OSDI score before surgery, they still complained of dry eye related symptoms 3 months after LASIK, and 4% of them had very severe symptoms which actually affected their quality of life. Now, why are we discussing this? So, yes, the patient will be in discomfort. The patient is an unhappy patient. That is there. But along with that, we should remember that untreated dry eye post refractive surgery can sometimes lead to very potentially vision threatening complications, like the patient may develop flap folds or flap displacement. They can come with refractive regression. They can come with microbial keratitis, usually in cases which are very severe and which are left untreated. The reason that the patient usually has refractive regression is said to be the epithelial, uh, the loss in the epithelium, that is the areas where there are development of SPKs. They can lead to epithelial remodeling. And this epithelial remodeling, hyperplasia, and underlying stromal remodeling can sometimes cause the regression to happen in these post-refractive patients. Now, dry eye disease is a very, very vast topic. And now it is, other than refractive surgeries also, it is one of the leading causes of ocular morbidity in the world. Increasingly, more number of patients are dealing with dry eye related complaints, especially in this era where the screen time is high in most patients. But sometimes, other than the environmental factors, these dry eye diseases can be iatrogenic. That is, they are secondary to any medical or surgical intervention, which can be in the form of medications, contact lens use, or sometimes post surgery, like our topic for today, that is especially refractive surgery. So, if we move on to the definition and the basics of dry eye, we have to understand that it's always a multifactorial disease. And there is importance of each and every component in this definition. So the ocular surface inflammation plays a role, the neurosensory abnormalities add up, and there is loss of homeostasis in this condition of the ocular surface. It's also important to note that the incidence of dry eye after surgery is always related to the basic status of the ocular surface before surgery. So what the study by Albitz et al. Tells us is that the risk of the patient developing chronic dry eye after LASIK in this study was associated with dry eye symptoms before the surgery. And therefore, it is very important for us to manage the ocular surface pre-operatively, if possible, because that would lead to lesser chance of the patient developing chronic dry eye symptoms after having the refractive surgery. So when we are seeing the patient pre-operatively, what are the predisposing factors that can tell us that this patient may develop chronic dry eye after surgery? So almost 8 to 55% of patients who are being planned for refractive surgery will suffer from dry eye disease. So Scanlon et al. Reported that about 1/5 of their patients who had mild symptoms before surgery then progressed to develop moderate or severe symptoms after LASIK. And if the patient has pre-existing dry eye, then that is of course a risk factor. But what is also important is what you're treating. So if you're treating a higher preoperative refractive error, then you have to know that it will have an increased risk of dry eye because there is increased stromal ablation, details of which I will be dealing with in the etiopathogenesis part. There are few more risk factors that you should see in a patient preoperatively, like females are at higher risk of developing dry eye. This is related to the lower percentage of androgen hormones in females, which are related to the tear production by the lacrimal glands. Patients who are at an older age, Asians, contact lens users, another very important risk factor, because most of the refractive patients are high myopes or sometimes even moderate myopes. They do rely on contact lenses for their cosmetic needs, or sometimes if they're not comfortable with glasses. And the contact lens, when used chronically itself, predisposes the patient to developing dry eye. Patients who are diabetic, and if there is any eyelid anomalies, these are further risk factors for the patient to develop dry eye postoperatively. Intraoperatively also, the surgical technique, the amount of stromal ablation or tissue removal, the ablation profile, flap diameter, thickness, as well as the hinge position, all of these factors can affect the development of dry eye. In the surgical techniques, like we discussed, the lenticule-based procedures are said to have a more favorable response in terms of the corneal sensitivity and dry eye manifestations as compared to LASIK. However, when you do a complete literature review, this may be a little controversial because we have studies supporting both. Some studies do say that the lenticule-based procedures do better in terms of the dry eye, but some studies clearly state that the tear factors and the dry eye factors between LASIK and lenticule-based procedures do not vary much. Surface ablative procedures such as PRK definitely do have lesser tear dysfunction and dry eye symptoms when you compare it to LASIK. But sometimes PRK patients complain of more dry eye related symptoms as compared to LASIK at 3 months. One of the reasons that even the authors say that this may be a possibility is because LASIK patients tend to have more neurotrophic corneas, and therefore their sensitivity is lower. So they may not feel the symptoms as much as a patient of PRK. When we are doing a hyperopic ablation, it leads to greater denervation because the nerve density of the cornea is more in the periphery as compared to the central cornea, and that is the area that we are ablating in hyperopic ablations. Thinner flaps have faster recovery of dry eye symptoms and corneal sensations because we are doing a shallower lamellar dissection. There is less volume of tissue through which the corneal nerves have to regenerate. In the topic of hinge location, again, nasal hinge flaps have been reported to produce lesser dry eye symptoms, faster recovery of corneal sensations. The reason being that because the nasal hinge damages the corneal nerves lesser, so they have dry eye symptoms which are milder. A horizontal hinge leads to less corneal sensory disturbances and dry eye as compared to a vertical location. But even when studies tried to compare at the end of 6 months, again, there was no statistically significant difference between the two groups. So the hinge location may also have an effect, but usually just in the early postoperative period or maximum up to 6 months. So having discussed the predisposing factors, why are these patients developing dry eye in the first place? So the most common pathogenesis that has been advised or advocated is that there is denervation of the cornea, leading to decreased corneal sensitivity. So not only the flap creation, but the excimer photoablation itself in LASIK and the femtophoto disruption of the stroma in lenticule-based procedures leads to partial denervation of the cornea. Even when we are doing a surface ablative procedure such as PRK, we are damaging the subbasal plexus, though the deeper stroma vessels are less affected in PRK, and therefore these patients may have lesser chance of developing dry eye. Now, the decreased corneal sensitivity in itself affects the ocular surface lacrimal gland neural loop because the afferent nerve fibers from these cornea are connected to the efferent fibers to the lacrimal gland, and therefore there is decreased tear production when these efferent nerves have been denervated. So this is a pictorial representation to understand that the long ciliary nerve which enters the globe posterior, that is close to the optic nerve, runs forward, enters the cornea through the limbal plexus at the mid-stromal level, and then moves anteriorly to form a subbasal plexus and the terminal nerve endings which are just close to the epithelium. So this is how there is a subepithelial plexus, the subbasal plexus, and you have sensory nerve terminals just close to the superficial epithelium. And these are the nerves that are getting transected when you're doing a refractive surgery. A comparison directly between LASIK, which is a flap-based procedure, where you are transecting three sections of the nerve, but some nerves are retained, which are in the area of the hinge, whereas in SMILE, most of the nerves are left behind. So theoretically also, the lenticule-based procedures should have lesser symptoms of dry eye, and the risk of developing dry eye should be lesser. So not only the afferent nerve stimulation leads to increased tear production from the lacrimal gland, but it also causes the patient to blink and causes reflex tear secretion. Now we know blinking is very important even for the meibomian glands to function properly and for the lipid layer to be formed well. As well as the afferent nerve stimulation causes release of epidermal growth factors and vitamin A, which are again very necessary for maintaining the normal tear film anatomy. Because the vertical side cut of the cornea in SMILE is shorter than that in LASIK flap, there is less disruption of the normal corneal nerve anatomy. However, like I said, at 6 months postoperatively, the studies do not show any difference in the corneal reinnervation and sensitivity between the two procedures. We have some advanced investigations also available, which show us exactly how the corneal nerves are cut post-refractive surgery. And when we do a serial imaging on a machine such as a confocal microscopy, we can see that slowly these nerve fibers regenerate, and therefore it is a temporary change. But the regeneration may take about 3 to 6 months. And in some patients, the regeneration takes almost up to 1 year post-surgery. Other tests, like using the esthetiometer to actually check the corneal sensitivity, also shows that the corneal sensation recovers to the preoperative levels by only around 6 months post-surgery. So this is a confocal microscopy images of the pre-op and post-operative subbasal corneal nerve fiber layer at 1 year after PRK. So the first two images are after PRK, after LASIK, and after SMILE. So if you see, the corneal nerves look least in the postoperative period when they have compared in the patients who underwent LASIK as compared to PRK and SMILE. Now the second pathogenesis is, like we discussed, that the blink rate is reduced. So because the corneal sensitivity is reduced, it affects the corneal blink reflex, and there is reduce in the blink rate. Because blinking contributes to the expression of sebum from the meibomian glands in the eyelids, so the lipid layer secretion is also dependent on the blink. And when there is a reduction in the blink rate or an incomplete blink, it results in reduction of the lipid secretion, and the patient has evaporative dry eye disease component along with the aqueous deficiency dry eye disease. The third very important etiopathogenesis cause is the inflammation. Now, when a person is undergoing a refractive surgery, there is definite increase in the pro-inflammatory tear mediator levels, IL-6, MMP9, which are also nowadays measurable directly, increase in inflammatory biomarkers like neuropeptides and neuromediators. And this upregulation has also been found to be less and the recovery faster with SMILE when we compare it to LASIK. The third reason for the patients to develop dry eye is that there is a corneal curvature change. Because the ablation makes the cornea flatter, there is a change in the corneal curvature, and this alters the friction between the cornea and the lid and leads to an unstable tear film. Another cause for the patients to develop dry eye is that during the refractive surgery, the pressure that is exerted due to the suction, it damages the conjunctival goblet cells, which we know are responsible for producing the mucin layer of the tears. And in addition, the corneal nerve disruption itself also alters the membrane-associated mucin expression, and therefore the tear film that is formed is very unstable. Again, the loss of goblet cells was found to be more with femtosecond LASIK because of the pressure applied due to the suction as compared to the use of microkeratome. So this is a very interesting study that I came across during the review of the literature that states that the dry eye symptoms, Schirmer's value, and the TBUT remain unaltered, or the fluorescein staining also increased slightly only after an enhancement as compared to the primary refractive surgery. So the reason here was not very clear. However, one of the possible reasons was that the patient's dry eye symptoms and signs may have been masked by the use of artificial tears, which were used continuously after the primary refractive surgery. And maybe the neurotrophic effects that were lost after the first surgery had not completely recovered. Therefore, the patient did not have symptoms as much as a primary refractive surgery. Another very important cause or parallel diagnosis with dry eye that we need to remember in refractive patients is something called as neuropathic corneal pain. Some studies call it pain without stain. This is basically corneal allodynia, corneal neuralgia, corneal neuropathy, or keratoneuralgia. It has been given various terms, but what basically means is that the symptoms are overlapping with patients who actually have complaints of pain, discomfort, burning, but there is no actual ocular dry eye related cause for it. It could be neurological, it could be psychiatric conditions, or there could be a non-ocular cause. The classical feature for this would be disproportionately increased symptoms of the patient as compared to signs. Sometimes it is necessary to start the patients on drugs such as pregabalin or gabapentin to help them with this neuropathic pain. When we do the preoperative evaluation of a patient for refractive, of course, in the history taking, we need to ask them about the contact lens intolerance, which in itself is a sign that the patient may be having dry eye. When they say that they cannot tolerate a contact lens well, you need to ask for history of any allergy, use of any medications, previous chemical injury, and chronic use of anti-glaucoma medications. Any important systemic comorbidity like rheumatoid arthritis, Sjogren's syndrome, rosacea, or SLE. And in case any of these systemic comorbidities are detected and are untreated, it is best to refer to an immunologist or a rheumatologist to take control of the systemic condition first. Various patient questionnaires are available, which are very important because they give us an exact idea about the symptoms of the patient. And the commonly used questionnaires are Ocular Surface Disease Index, Dry Eye Questionnaire, and Impact of Dry Eye on Everyday Living. So these questionnaires have a set of questions for the patient, the response on which is scored. And based on the score that the patient has, the diagnosis of the level of dry eye can be made. And it gives you an objective measurement of how the score is and how much dry eye the patient has. After doing an evaluation, you can ask the patient for any clinical symptoms. What happens is that along with dryness, pain, stinging, photophobia, redness, and visual fatigue, the patient will also complain of fluctuating vision and sometimes impaired functional vision because the unstable tear film itself causes irregular astigmatism. Usually post-surgery, the patients will be bothered most by this during the first month, and then slowly they gradually improve over the next 3 to 12 months. In the post-operative period, a complete assessment of the ocular surface is important, including the meibomian glands, the blink patterns, the tear film, the conjunctiva, and the cornea, measurement of the tear meniscus height, followed by the Schirmer's test, the tear film breakup time, and the ocular surface staining using the different dyes should be made. The tear meniscus height is the height of the tear film that is seen at the lower eyelid. Most reliable method of measuring it is by the OCT imaging. However, slit lamp imaging with a reticule is also very useful for measurement of this meniscus, with normal levels being between 0.2 to 0.3 mm. The procedure of Schirmer's test, for the ease of understanding, it basically tells us the wetting of the film of the paper that is inserted into the lower fornix. Anything below 5 is insufficient tear production. 5 to 10 can be possible shortage. More than 10 to 15 is usually normal tear production. When you look at the tear film breakup time after staining the patient with fluorescein dye, and after the patient has blinked 2 to 3 times, you ask the patient to hold the blink and look for the first appearance of the dry spot, which will then progress to an area of dry patching. So when the first dry spot appears, that is the normal tear film breakup time. Usually more than 10 seconds is considered normal. When you look at the meibomian glands, you can grade the loss of meibomian glands by different grading systems. The most commonly followed one indicates that less than 25% mg loss is grade 1, 25 to 50% is grade 2, 50 to 75% is grade 3, and more than 75% is classified as grade 4 MGD. It is also very important to look for a characteristic pattern of corneal staining that has now been termed LASIK-induced neuropathy line, which is seen in post-refractive surgery patients, especially when they are very symptomatic, and this indicates that there is an ongoing inflammation or dry eye in the patient. So when we seek the basic tear tests like Schirmer's test, 1 month after LASIK, 60% of patients will have an abnormal Schirmer's value, 69% will have an abnormal T-butt, and the mean Schirmer's 1 and 2 value will be decreased by as much as 30%. And 72% of patients who had a Schirmer value less than 10 preoperatively will have dry eye 1 month after surgery, as compared to only 46% of patients who had Schirmer 1 value more than 10 mm. This is the basic in-clinic diagnosis of dry eye that we were talking about, but we have advanced techniques like interferometry, which measures the exact nature, lipid layer thickness, and the lipid layer film breakup also. And meibography can also be done better on the interferometry machine to assess the morphology of the meibomian glands. So this is a printout of how the ocular surface analyzer looks, where they give you the value of the knee butt, the lipid layer thickness, the exact tear meniscus height, mg loss lower as well as upper, which can be seen in the clinic, or machines like the ocular surface analyzer can be used to have a pictorial representation of the same. Like we discussed, the confocal microscopy itself can be done if possible and available for the number and density of the subbasal and stromal nerve cells, which are generally deranged in the dry eye related conditions. There is abnormality in the nerve morphology, such as bead-like formations, microaneurysms, increased tortuosity, irregular branching, and increased corneal dendritic cell density, which are also seen in patients who have dry eye disease. Very interestingly, now they are also moving to use of an objective tool, which is the epithelial thickness on ASOCT, which also can diagnose dry eye or have an objective tool to diagnose dry eye. So in the first picture, what you see is a patient 1 month post-LASIK for myopia. Central epithelial thickness is 58, but the epithelial variability around the cornea was noted to be higher. And when they saw the Schirmer's, that had also decreased from the preoperative value to the postoperative value. Now, the same epithelial map, when it was repeated at 6 months postoperatively after treating the dry eye, 5 months with cyclosporin, the central epithelial thickness had reduced to 56. And so they say that the presence of epithelial thickness variability itself can also be an objective tool for diagnosing dry eye in post-refractive patients. There is also availability of kits that are called by the name InflammaDry, which is for measuring directly the inflammatory biomarkers in the tear film, where MMP9 is a major biomarker which can be studied directly and in the outpatient clinic. And the tear film MMP levels are indicative of the patient having dry eye and the severity of dry eye. So like we discussed the various tests, this is just a summary of all of them. So when you stain the cornea, there will be positive staining at 1 week, usually in the flap in LASIK, less severe in SMILE. And this usually resolves by 6 to 12 months after LASIK, a little earlier by about 1 to 3 months after SMILE. The tear film breakup time will be definitely reduced, most severe at 1 week. Again, this can normalize by about 6 to 12 months post-LASIK, 3 to 6 months after SMILE. The Schirmer's test will be reduced maximally during the first month, normalizing by about 6 to 9 months after LASIK and by about 3 months after SMILE. including the other dry eye symptoms, the lipid layer thickness, the tear osmolarity, the nerve morphology. So all of them will show that in the immediate postoperative period, the patient will have a reduce in these tear film, the tear um, parameters. Even the nerve morphology will be reduced, the subbasal as well as stromal nerve cells. But these are all temporary changes, and usually recovery will happen, usually up to 6 months and sometimes up to a year's time. Now, having discussed the pathogenesis, the clinical symptoms and signs, now that we have patients with us, how do we manage them? So the most basic treatment would be to start them on tear substitutes. There are various tear substitutes available which can be used in these patients in the frequency which matches their symptoms. Sodium hyaluronate especially is said to have additional wound healing properties. It's also so in the presence of epithelial dysregularity or presence of superficial punctate keratitis, it can be important to start sodium hyaluronate as well along with the basic tear substitutes. And because the preservatives in these substitutes can increase the inflammation, so it is advisable to use preservative-free medications, especially because the patients may have to instill the drops more than 4 times a day over long periods of time. Benzalkonium chloride and chlorobutanol preservatives in excess damage the corneal epithelium, and so the symptoms can start mimicking the dry eye disease itself, and therefore a differentiation and diagnosis is important. Newer preservatives like purite, sodium perborate are shown to have less harm to the ocular surface as compared to the traditional preservatives. It is very important to understand because the underlying cause of these dry eye is inflammation. So along with the treatment by tear substitutes, it's important to start these patients on anti-inflammatory medications. Usually most of them are on a topical steroid regimen post-surgery, but sometimes it may be important to start cyclosporin and other immunomodulators also. This helps in reducing and breaking the inflammatory cascade, and then the patient will be relieved of the symptoms and the disease can be treated. So the use of topical steroids, it blocks the inflammatory cascade by blocking the cyclooxygenase. The topical steroids can be used for up to 4 to 6 weeks in tapering doses, and the strength and frequency of the steroid usually depends on the severity of inflammation in the eye. Immunomodulators like topical cyclosporin A, they act by preventing the activation of T cells and therefore the production of inflammatory cytokines. It is important that the topical cyclosporin is usually prescribed for a minimum duration of at least 3 months because the onset of action is slower, and sometimes the cyclosporin can be started preoperatively as well if the patient is having dry eye preoperatively. And post-operatively, it has to be started along with topical steroids to ride over the initial period where the cyclosporin effect may not have started. There is availability of newer drugs like lifitegrast 5%, which blocks the interaction between two cell surface proteins, LFA1 and ICAM1, which are the basic reasons for the inflammation to occur in these dry eye patients. This prevents the activation and migration of T cells and therefore reduces the inflammation. And it also prevents the excessive immune cell infiltration and activation. So these drugs are now being commonly used for dry eye in patients who are already on cyclosporin and may not have responded very well to just cyclosporin. However, we do not have studies on these newer molecules, especially in post-refractive patients. So the use is still controversial. Theory also tells us, different studies tells us that there are availability of dicufasol tetrasodium, which is an agonist that facilitates mucin production, because we saw that the decrease in mucin layer is also one of the reasons why these patients are having dry eye. And therefore, if the mucin production can increase from the conjunctival epithelial cells or the goblet cells by use of DQS or ribupamide 2% solution, it can help to decrease the dry eye related signs and symptoms and improve the optical quality. So sometimes autologous serum can be given to the patients because this autologous serum, which is made from the patient's own blood, has neurotrophic and epitheliotropic factors. It has nerve growth factors in substance P, epidermal growth factor, vitamin A, and a lot of anti-inflammatory factors and inhibitors of the MMP9. So patients of LASIK-induced neurotrophic epitheliopathy or dry eye can benefit from autologous serum therapy when everything else is not helping them much. But of course, the limitations of preparing the drop from the patient's own blood and the limited shelf life of up to a week when it is stored at 4 degrees Celsius and up to 3 months when stored at minus 20 degrees Celsius have to be considered when we are prescribing the same. Uh, Procedures such as punctal plugs do give a lot of symptomatic improvement to patients of dry eye. Some studies also advocate that there can be preventive implantation of punctal plugs during LASIK procedure itself in patients who already had preoperative dry eye and where it was expected that the patient may develop chronic dry eye symptoms. Or sometimes in the early postoperative period also, in high-risk cases, use of punctal plugs can be considered with an understanding of the possible complications of loss of plugs, epiphora, and granular formations. In very advanced cases where the topical medications or the punctal plugs are not helping, it is important to consider the possibility of using scleral contact lenses because these scleral gas permeable contact lenses improve the comfort in patients with post-LASIK dry eye because there is a prosthetic replacement of the ocular surface which supports the healthy environment for the ocular surface. Of course, these are options for very severe dry eye where the patient is very symptomatic. Along with treating the basic dry eye disease, always look for meibomian gland dysfunction like we discussed, which causes a lot of evaporative dry eye component to the patient and the dry eye just gets added up. If there is a meibomian gland dysfunction that you're diagnosing before refractive surgery, please treat it before planning the surgery. You can ask the patient for good lid hygiene, advise them for warm compression, gland expression, oral and topical medications, or the newer procedural therapies like thermal pulsation system or intense pulse light therapies. These help in preoperatively improving the quality of tear film that the patient has, and therefore the development of postoperative dry eye goes down. Usually it is said that it is best not to perform these procedures in the early postoperative period to avoid any flap-related issues. Now, the mechanism how these intense pulse light therapies acts is multifactorial. So there is a local warming of the meibomian gland that happens, leading to melting of the thickened meibum secretions. There is also a reduction in the bacterial and parasitic growth on eyelids. And the wavelength of IPL directly targets the oxyhemoglobin in the superficial skin vessels. And therefore, there is photothermolysis of these vessels, thrombosis of vessels, thereby reducing the cytokine leakage and the inflammation. And it has a photostimulatory effect on the mitochondria of MGs itself, promoting cell activity such as photorejuvenation and wound healing. So by multiple mechanisms, by reducing the lid inflammation, by opening up the meibomian glands, the intense pulse light therapy can be an effective treatment preoperatively for these patients if you diagnose them to have meibomian gland dysfunction. The use of oral essential fatty acids such as omega-3 fatty acids like eicosapentaenoic acid, docosahexaenoic acid, plant-based sources also improve the symptoms and decrease inflammation and ocular surface staining, but not all studies support the use of these medications. There is a role of vitamin D. So sometimes if the patient is not responding to any treatment, it may be even advisable to get the vitamin D levels checked because vitamin D has a very important role in wound healing. And it has been found that it has a definite association with the corneal dendritic cell density and inflammatory factors. So sometimes when the patients are not responsive to conventional therapy, oral vitamin D supplementation can also be started. So this is a synopsis of what all we have discussed, where you have to clinically evaluate the patient by doing the tear film parameters such as Schirmer's, T-Butt, stain the cornea and conjunctiva, have some questionnaires ready. And if you diagnose them with aqueous deficiency dry eye and evaporative dry eye together, just grade the severity of mild, moderate, and severe dry eye disease. If it is mild to moderate, you can treat the dry eye and then you can proceed for refractive surgery. If the patient comes post-operatively with symptoms of dry eye disease, you re-evaluate the patient for dry eye and the grading at present, that is post-operatively, and then you treat it as per the type and grade of dry eye. But however, if you're diagnosing the patient to have severe dry eye disease because of a mix and match of both aqueous deficiency and evaporative disease, and you feel that there is a neuropathic dry eye disease, that means the patient's symptoms are already higher than the signs there may be a possibility of corneal nerve related changes, and the patient has severe dry eye disease, then it may be best to avoid refractive surgery or have a proper counseling with the patient before planning the surgery. Once you have a patient who has dry eye disease, you have to base the treatment on the type of the dry eye disease, where the aqueous deficiency dry eye disease is most commonly managed with preservative-free lubricating drops, gels, and anti-inflammatory agents. Additionally, you can give them essential fatty acid supplements, try for punctal occlusion. For very severe cases, oral pilocarpine may be started. For the evaporative dry eye disease, treat the MGD, have lifestyle modifications, ask the patient to have a lot of warm compresses, lid hygiene, along with lubricating eye drops, and sometimes intense pulsed light if the patient is having chronic or severe MGD. In patients of neuropathic pain, where you may not see much signs, it is best to consult with a neurologist, where they can be prescribed some oral medications that help them with the pain. Though topical cyclosporin eye drops can be started, as well as autologous serum eye drops may be given because they do help in the neuropathic pain. Always keep an eye for toxic dry eye disease, where you will get SPKs outside the flap. Usually these are drug induced, so you may have to change to preservative free drops and give topical anti-inflammatory agents for a short period of time. So just some important studies that were done for dry eye after refractive surgery. Here they wanted to evaluate how the meibomian gland status affects the development of dry eye post-operatively. They had 78 patients who underwent 3 different types of refractive surgeries. Interestingly, pre-operatively, there was no difference in the OSDI scores based on the meibomian gland loss percentage. But post-operatively, the difference became significant. So pre-operatively, though the MG loss did not have much symptoms, post-operatively with the additive effect of the inflammation and the corneal nerve transaction, the patients became more symptomatic. So it becomes important to treat the MG meibomian gland dysfunction even if the patient does not have a lot of symptoms pre-operatively. Again, like we discussed that the SMILE patients as compared to femtolasic patients always have faster recovery. The values of their TFN parameters do come back to preoperative values earlier. But in the end, if you look at 6 months or 12 months outcome, the incidence of dry eye may not be very different between the two groups. This is a very good meta-analysis where they went through a lot of studies related to dry eye post-refractive surgery, and they said irrespective of whether it is a femto lenticule-based procedure or a LASIK, the patient is going to have a significant reduction in T-bud time. But lenticule-based procedures like SMILE and PRK, the reduction is lesser. So it is not a significant reduction when you compare them with procedures such as LASIK, where the decrease in tear production is higher. So my take-home message from this would be that dissatisfaction post-refractive surgery can always be dry eye related. So even if the patient has 6/6 vision, you feel that everything is fine. But if the patient is complaining, you have to evaluate the patient for ocular surface abnormality. Sometimes the patient may have more symptoms, not much signs or not correlating severity of signs. In these cases, we keep in mind that it could be a neuropathic pain. It is very, very important to have a good preoperative evaluation of dry eye disease in all these refractive patients, because that is where we can treat the dry eye before we go for a refractive procedure. And counseling a patient along with medications is usually more important, where you can tell them that it may not be long lasting. As and when the corneal nerves regenerate and with the use of medications, most of these patients will improve, but you have to counsel them to keep patients for the same. Thank you.
That was a very elaborative class, ma'am. Very nicely taken. And you've covered almost everything. There's nothing left to discuss here. Dr. Arvind, sir, do you want to add something to what Dr. Akanksha has already mentioned?
Yeah, of course. It was an excellent talk. Many congratulations, Dr. Akanksha. You deserve, means hip hip hooray for your presentation. You covered the entire paraphernalia, no doubt about it. So I would like to add a few things. So you missed the role of tree halos. in the management of post these keratorefractive procedures. So according to there are two studies only. There are not much studies, but still there are two studies. So one study is from Spain. It's a PubMed study by AJM Orobia. So they said that definitely the tree halos, if it is 3% tree halos is added along with the lubricating, so it is very effective in managing the post these LASIK procedures dry eye. Also, when we talk about the PRK, so there are studies that the epithelial healing is faster when the tree halos is given. So there is a study by CG Crader. So all the residents, they can search. The first study is by AJM Orobia from Spain, and the other study is by CG Crader. And now coming to the other part, that is the cyclosporin. They have a very definitive role, but most of these, for the knowledge, for the sake of knowledge of all the residents, so they have this lipid, anionic lipid emulsion. So whenever there is some oil formulation is there along with any salt, so it decreases the penetration in the eye. So the actual penetration is very less. So now there are liquid-based preparation like Sequa. So they enhance the penetration and also the irritation is less. And also you have rightly said that the pre-op evaluation is very important. So we need to look for any subclinical inflammation. We need to evert the eyelid and we need to do a thorough checkup, slit lamp examination along with OSDI, T-birth, shimmers, and the Van Bisterwale scoring and everything. So sometimes there are subclinical inflammation. So we need to treat those inflammatory part first, and then we need to go for the LASIK procedures. So this is what my experience. So this is what I wanted to share with everyone.
Sir, do you consider starting your patients on any preoperative medications if you suspect that they have dry eye? Like, do you use preoperative medications? Or
Yes,
like,
yes. If we suspect there is dry eye and the patient is adamant that they want to go for LASIK surgeries. So if it is a moderate type of, okay, so then we start with the sodium hyaluronate plus the trihalube combination and sometimes Sequa along with it if we find there is subclinical inflammation is there. And the mild fluoromethalon steroid also, it is very helpful. And we wait for months, we do follow up and we wait for the all the T-bird shimmer to improve and then only we go for the LASIK surgery.
yes.
Because these patients are very demanding. So they don't means want any means even the mild discomfort. They are very means uncomfortable with that.
Ma'am, I would like to ask one question. In cases where you know that the patient has dry eye, does your choice of refractive surgery also depend on the patient's dry eye status? Like any particular procedure that you definitely change to or consider if the person has a dry eye component significantly preoperatively?
Anika, like sir said, I would also believe that if the patient actually has moderate to severe, then it's best to treat the dry eye rather than change your procedure. But if the patient is on well, maybe mild dry eye after you've controlled them on from moderate to severe, theoretically, yes, I would prefer to do a lenticule-based procedure as compared to LASIX. But like I told you, like most studies say that in the end, maybe after 6 months, the corneal nerve generation is the same. So I would not base my surgical procedure only on the presence of dry eye, maybe other symptoms like presence of astigmatism. So if I have multiple factors to change my procedure, then yes. Otherwise, for moderate to severe, I'll just wait rather than changing my procedure. I would control the dry eye and then go ahead with preferably a lenticule based procedure.
Also, ma'am, in cases where there was a history of some kind of viral inflammation, but the cornea is clear, there's no vascularization, do you think that also impacts the surface structures and also the performance during and after the surgical procedure?
Yes, Kanika, because post viral, you would expect them to anyway have a neurotrophic cornea. So the nerves are not very healthy. So ideally, a history of viral keratitis should again be a relative contraindication for you to do a corneal ablative procedure. If it is a missed viral diagnosis and you end up doing a refractive procedure and then it happens, then you can only treat with antivirals along with anti-inflammatory. But because the corneal nerves are weaker, if there's a established viral keratitis diagnosis, then I would avoid refractive surgery.
And what about, ma'am, adenoviral? Sometimes we see people, they don't even realize they had an adenoviral conjunctivitis episode, and they land up with this very small, minute nummular opacities, which are not very deep, although they do affect the cornea, although their vision quality in all is not affected much. They're not even aware of it many a time. So, how do we proceed in such
So
cases?
as compared to herpes simplex, adenoviral has less effects on the corneal nerves. That is the reason it is usually not recurrent. So adenoviral would not be a contraindication for me to do a refractive surgery, but I would wait for the scars to lighten up because that would affect the firing of the laser itself. So maybe start them on cyclosporin, put them on topical steroids for some time till the density of the scars are less. But if you have a history that the patient had these scars which are now maybe light or absent, then I would go ahead with surgery. So your take on this, sir, for
Yeah,
adeno?
I agree with you. I first treat them, wait for some time, and these steroid and these cyclosporin works very well most of the time.
Sir, I would like to ask, what is your preferred duration of observation in such patients where you start them on therapy? How long do you wait for the symptoms to resolve, and when do you decide to go
Yeah,
ahead?
so first, when it is accomplished that it is there, dry eye is there. So first means we need to start all the therapy, and follow-up is very important. First, it will be a short follow-up or a week or a bi-weekly, and then later on we can wait for a month and wait for the symptoms to improve.
So let's say, sir, if a patient is not improving beyond 1 month, then would that be a contraindication to proceed with surgery? Would you like to treat the patient for a longer duration, probably 3 to 6 months before planning the process?
Of course, because we are dealing with the cornea, and there will be some means the inherent changes in the nerve supply. Right, that will be affected, and that will lead to the tear secretion and everything. So if it is still there after 1 month treatment, yes, I have waited for 6 months. Even in few cases, we have waited more than 6 months also. We waited for 9 months.
Okay. Ma'am, one more question for you. We've seen most of the people who present in dry eye clinics sometimes have associated hormonal issues or thyroid disorder or rheumatoid arthritis. Even if such patients do not have clinically important present signs, do you still think that these patients should be treated with caution, or whether we should inform them something preoperatively, or we should again give them an intense anti-inflammatory dry eye therapy first and then proceed with the surgery?
If there are no clinical signs of dry eye, I wouldn't preoperatively start them on any medications. Yes, you can have a word with the patient that you are at higher risk of developing dry eye postoperatively. So maybe your steroids may be longer based on your dry eye symptoms post surgery, or you may continue cyclosporin longer. But preoperatively, only if you see clinical signs, you should start the patient. And again, it will not be a contraindication if the patient has thyroid to do a refractive surgery unless they have moderate to severe dry eye.
Also, ma'am,
And
like you already
along
talked
with,
about
I would
vitamin.
like to add these thyroid patient along with smoking habit.
Yes.
Then we need to be very cautious. This is my experience because in two patient they were smokers, and somehow we missed in the history, and later on we have to face a lot of challenges, and it was taken a long time to treat dry eye symptoms.
Yes, sir. Ma'am, you also commented about vitamin D. So, does vitamin A level also affect the dry eye levels pre and post surgery? And should we make this a routine part of all the investigations that we're doing pre-operatively, like vitamin A, E assessment, D assessment prior to refractive surgery?
Of course, Kanika, vitamin A will also have a role in the dry eye, but to make it a part of all pre-op refractive may be an overkill because, and practically all of us, if you see, are low on vitamin D nowadays. So most of the patients would just be started on vitamin D pre-operatively. But like I said, that sometimes we have patients, you've tried everything and they're not improving. They keep complaining. So there, maybe you should early on only decide in the post-operative period that let me get the vitamin D levels checked. I can at least give some supplements if needed. Vitamin A, usually if it is severe enough to cause dry eye, you may see bite or spot, or you may see some sign on the eye that tells you vitamin A deficiency is there. But vitamin D is something that is missed easily because most of us are low on it, but we don't routinely get investigated, especially young patients. They are more indoors nowadays. So if a young patient is showing us dry eye which is not responding to traditional treatment, only then, I think not for all preoperative patients.
It is not indicated in all the patients preoperatively, these investigations.
We would have a battery of tests then to
Yeah,
investigate
True,
everything.
ma'am. But then again, like sir said, that these people are very demanding, and sometimes they keep asking for answers and they keep putting up these questions repeatedly in spite of explaining, counseling, and all those stuff. So, of course, we should have something in our armamentarium to, evaluate and to at least satisfy their curiosity, like what is happening, why my nerves are not generating at that speed. Many people in their post-op period are very concerned that I'm still having a lot of discomfort, dryness. I can't use my laptop very often. I'm not able to use my phone for longer duration. So all these complaints are there. Like they are at times very, very dissatisfied just because of the irritation part. And the vision wise, they are happy, but still.
So,
Uh,
Kanika, that is the reason because see, sometimes we forget that because our cornea is so densely innervated, that the symptoms that the patient is undergoing is actually quite severe, which we may not relate to, but it affects their quality of life. So, if the dry eye is actually left untreated, even if the vision is 6/6, the patient is going to be unhappy. So, we have to actively treat the dry eye, and that is why there was a special mention of the neuropathic pain because that is the entity that's now being recognized that sometimes patients are on cyclosporin for 6 months, 9 months, steroids for 6 months, 9 months, and but when you see their cornea, the tear meniscus height, everything is normal. So there we are just treating the wrong diagnosis, and that's why the patient is not improving and we are not happy. So with proper evaluation of grading, and once you have labeled a patient to have dry eye, it's going to be a diagnosis of momentum. Every time they go to anybody, they're going to say it's because of dry eye. So the patient becomes unhappy that if I have dry eye, why isn't it being treated? So there, then if you're seeing that the symptoms of the patient are quite high, but we don't see any clinical signs much of dry eye, I think we can either some practitioners do themselves start on these nerve modulating drugs, or you can refer to a neurologist. I have seen few patients who feel much better after gabapentin or pregabalin is started for a short duration. So, of course, it's not a very big percentage of patients, but they should also be adequately treated rather than thinking that they just have dry eye, so let's continue them on cyclosporin.
True, ma'am.
rightly said, Dr. Akanksha. And most of these patients are there. If we see their lifestyle, so most of them are using laptops, and
Yes.
we are overtly dependent on these digital devices. So we need to look for those lifestyle modifications also. So in few of the patients, the rule of 20-20-20, because there is when we tested for them for the dry eye, so there was incomplete blinking. So
Yes.
there are a lot of things, and the AC, they are sitting in front of the AC. So these are a lot of small, minute changes in their lifestyle that can also help in improving the dry eye symptoms.
Yes.
Sir, another question to you. Most of these people nowadays, the youngsters, they are mostly working on their PCs at all times. So even after refractive surgery, they do come up with questions like, should we wear some computer glasses or some blue filter, blue cut lenses? Do you think that plays a role in the dry eye as well post-operatively? And what would be your advice to such people?
Most of the screens are now anti-glare, so we don't have to worry about that part. But means for the placebo basis, we have seen that if we advise them anti-glare glasses, they were very happy. Yes, sir, now I'm all right. So that works well, and the patients are altogether different. So we need to customize our therapy for because one shoe doesn't fit all. So we
Yes.
need to have a customized approach. We need to listen the patient. I had seen in my experience that if we are giving time to the patient preoperatively more, so those patients they will means disturb you with lesser time in the post-op period.
Good stuff. Yes, sir.
So
Chair,
always listen to the
one thing
patient.
that we have learned in refractive surgery is very important, whether
Yeah.
it is dry eye or not. So, a very good session by ma'am and sir. Dr. Shreya, do we have any questions from any of the online platforms?
No, not yet. There are none.
Ma'am was so thorough.
Yeah.
Yes.
She is.
So I think, sir, we can call it a day.
Yeah.
Don't have any
So
further questions, and very nice presentation by ma'am and very detailed discussion. And we are so lucky to have Arvind sir as a chairperson here giving us insights. It was a very successful session, I would say.
thank you. Thank you,
So much.
Kanika. Thank you, Shreya. Thank you, Dr.
Thank you, sir.
Akansha.
Thank you,
And
Dr.
a
Kanika.
special thanks to Dr. Santosh Onava, Dr. Mahipal Sasdeva sir, for giving us all this wonderful opportunity to share our experiences and do something for the residents. Thank you. Thank you so very much.
Thank you, sir.
Thank you, sir.